Everybody, my name is Steve Perlman. I am from DelVal Senior Advisors. I am your instructor in today's Know Your Medicare Options educational only seminar. The reason we say educational only because there are regulations that say we have to say educational only. We follow the CMS guidelines for an educational only seminar. So to that, there's a couple of rules of the road. First of all, we do not receive registration information. That is so that nobody feels that they're going to be solicited after this. If you have any questions regarding Medicare or any concerns about your own personal situation, we ask that you just contact your advisor, and your advisor will get back in contact with me, and we will make sure that all of your questions are answered. We don't discuss carriers by name. I use fictitious names like ABC, XYZ, or Corn Cob, Nebraska. And we don't discuss plan-specific pricing other than pricing that is published by Medicare and the Center for Medicare and Medicaid Services. But by the time we get done with this seminar, from a budgeting standpoint, you're going to have an idea as to what to expect for you to either go on original Medicare, Part A, Part B, a supplement, and a drug card, or to consider going to a Medicare Advantage plan. This is a little bit of a different format for me. I'm normally a live person in front of the room taking questions as we go. I understand in this format, I will just be presenting. So along the way, what I will do is I will interject some of the common questions that I get during my seminars, and then I will answer those questions for you. So with that, I'm going to do a share screen, and we are going to get started. So this is a slide that we put into our seminar back in 2018 when Medicare changed the Medicare card for everybody. A lot of people that we find that are going on Medicare may have had experience with a Medicare card prior to their own enrollment into Medicare. Maybe they're helping their mom or their dad in their later years, and they were walking around with mom and dad's, Medicare card for them. You may remember that your Medicare card used to be your Social Security number with a letter at the end of it. Back in the 1990s, we invented this thing called the internet, and that very rapidly followed with this thing called identity theft. And it took Medicare about 15 years to catch on that maybe it's not a good idea to send senior citizens a card with their Social Security number on it, considering everybody had taken their Social Security card out of their wallet already. So they finally turned around and came out with this new 11-digit alphanumeric system that you were going to get on your card. And at the time when they first introduced it, there was only about 71 million people on Medicare, and they received this card in the mail, which did not have their Social Security number on it. And what do you think a lot of them did with it? You're right. They threw them away, thinking it was just another piece of advertisement, for them, or somebody was trying to sell them something. So I'm here to tell you that your Medicare card is going to look a whole lot like this. It's going to have your name as it appears on your Social Security record and your 11-digit alphanumeric number. And it's also going to have your Part A and Part B date. So let's talk a little bit about when to apply for Medicare. People go on Medicare typically for one of three reasons. The first reason people go on Medicare is they are what we call aging in. They're turning 65. If you are turning 65 and you are getting your health insurance from the exchanges, you are self-employed and on your own health insurance plan, you work for a small group plan. Small group plan is defined by the health insurance industry as a plan that has less than 20 eligible employees. So maybe you work for a small law firm. Maybe you work for a small financial planning practice. Maybe you work for a small doctor's office. Small meaning that there's, 8, 10, 12, 14, 16 people there. There's enough to have a nice holiday party, but there's not enough for that health insurance plan to stay as primary coverage for somebody who becomes Medicare eligible. So again, the first reason people are going on Medicare is they're aging in. Medicare is going to become their primary source of their insurance. So when should they apply for Medicare if you're aging into Medicare? Know that everything in Medicare begins on the first of the month. If your birthday is on Halloween, your first day of Medicare eligibility is October 1st. If your birthday is on Valentine's Day, your first day of Medicare eligibility is February 1st. If your birthday happens to be on New Year's Day, your first day of Medicare eligibility is, no, it's not New Year's Day. It's actually December 1st. So the wrinkle to the rule is if your birthday happens to be on the 1st of the month and you're aging into Medicare, your first day of Medicare eligibility is the 1st of the month prior to the month that you turn 65. Know that Medicare is never going to begin in the middle of the month. Medicare is always going to begin on the 1st of the month. So if you're aging into Medicare, you're turning age 65, when should you apply for Medicare? Very simple. Go to the 1st of the month in which you are qualified for Medicare when you turn 65, and just go back 3 months prior. So if you're going on Medicare for December 1st, you have November, October, September. The beginning of September is when you would apply for Medicare Part A and B. And then that would open up your initial enrollment window. Your initial enrollment window is defined as the 3 months before the month you turn 65, the month you turn 65, and the 3 months after you turn 65. That's your initial open enrollment window. So the first reason people are going on Medicare is they're aging in, they're turning 65. That happens about 45% of the time. About 45% of the time, people are going in Medicare because they're over 65, and they're now leaving employer-sponsored insurance, whether it's their own or their spouse's. A very common question I get is, if I'm on my spouse's insurance and I'm turning 65, do I have to do anything at that point? And technically speaking, if your spouse's plan is considered a large group plan, meaning that they have more than 20 eligible employees, technically speaking, you don't have to do anything. So if you are turning 65 and you're staying on an employer-sponsored plan, whether it's yours or your spouse's, what do you have to do at 65? Technically nothing. But my suggestion is that you apply for Medicare Part A only. Why? Because it gets you into the system, it gets your number and your Medicare card generated, and they'll send you a card and you'll have Part A in your pocket. If you're staying on an employer-sponsored plan and maybe you have a high deductible for hospitalization on that plan, Medicare will actually kick in as secondary coverage after the first $1,632. They just changed the number over the weekend. $1,632 of your deductible for hospitalization, Medicare will kick in and reduce your deductible. So if you have a $5,000 deductible for hospitalization, Medicare kicks in after $1,632, reducing your deductible, and then your health insurance will kick in after that. So if you're turning 65, you're staying on an employer-sponsored plan, my recommendation is that you apply for Medicare Part A, with the one caveat that you're not contributing to a health savings account. You really can't, you're not supposed to have Medicare Part A. Actually, technically by law, you're not allowed to have Medicare Part A and still contribute to a health savings account. But that's a little bit outside of the scope of this presentation. If that's a situation that pertains to you, please talk to your advisor and I can get you more guidance on that. So now you're over 65, you've applied for Medicare, you have your Part A card. When should you apply for Medicare Part B? My recommendation is give yourself as long of a runway as you possibly can. Typically, people aren't waking up on a Monday saying, I'm retiring on Friday. You want to give yourself a 60-day window, at least a 60-day window, so that you can get the form to your HR department, they can get it back to you, and then you can apply for Medicare Part B. What form is that? That's an employer verification form. What you want is you want that employer verification form so that you can say, I have had creditable coverage, meaning that it's at least as good as Medicare coverage. I have had creditable coverage since I'm age 65. When you file that form and apply for Medicare Part B, that form acts as your waiver of any late enrollment penalties. So you've had creditable coverage since you were 65, and you don't have to worry about paying any late enrollment penalties. That goes through the system. They then reissue your card to you with the Part A date and the Part B date on it. And once that Part A date and that Part B date are posted on your card, then you can apply for your supplement plans, drug cards, or your Medicare Advantage plans. So again, about 45% of the time, people are going in Medicare Part A because they're aging in, they're turning 65. About 45% of the time, people are going on Medicare because they're over 65 and they're leaving an employer-sponsored plan, whether it's theirs or their spouse's. That leaves about 10% of the time. About 10% of the time, people are going on Medicare because they're receiving Social Security disability income. When people are awarded Social Security disability income, typically that award is backdated by several months to the original triggering event. Once you've received 24 months of benefit, you then have to make all the same age 65 elections that everybody else does. So very often I'll get phone calls from people who are in their 20s, 30s, and 40s, even in their 50s, who are receiving Social Security disability, and they've now received notification that they're going on Medicare and they need to know what they're going to do next. Again, they have to make all the same elections. So with that, that's about it for the Medicare card. Not a whole lot of questions typically come up with this. It's more about how do I apply? So we're going to go to the next slide and we're going to talk about that. So there are really two ways to get to the main portal to apply for Medicare, either Part A or Medicare Part A and B. If you're applying for Medicare Part A because you're just staying on an employer-sponsored plan, or you're applying for Medicare Part A and B because Medicare is going to become your primary coverage at age 65, you can either go to ssa.gov/Medicare/sign up, or what I often recommend to people is to go to ssa.gov, socialsecurity.gov, and when you get on that main landing page and you scroll down about 3/4 of the way down the page, you're going to see something there that says My Social Security Account. When you click on that link, it's going to bring you to a login page, at which point it's going to either prompt you to log in because you've been there before and you've set up a username and password, or you're going to create an account and you're going to create a username and password and log in. Once you get to your page, there's a lot of really great information in there. There's your entire Social Security record. There is a very nifty chart that you can slide from side to side and determine what Social Security retirement income benefits you're going to get. But as you scroll about 3/4 of the way down that page, you'll see something that says Medicare benefits. And when you click on it, it's going to ask you, do you want to enroll in Medicare? And you just say yes, and you follow the screens. It's very, very simple. So if you're applying for Medicare Part A only, you'll click on the screens and move through and apply for Medicare Part A. If you're applying for Medicare Part A, again, you start in the same spot. There's just a little radio button there that says, do you want to apply for Part B? And you're going to go click. And as you go through all the screens, you'll apply for Medicare Part A and B. So again, you can use ssa.gov/Medicare/sign up, or as I recommend, you go to ssa.gov, you create a My Social Security account, and then you have a single login for everything. And that's the easiest way to do it. Now we're going to talk about Medicare and how it came to be and how it's actually built. So it's 1965. President Johnson signs into law the Medicare and Medicaid Act of 1965, effectively creating two government agencies. One is a health insurance company for people over 65. The other one is a financial assistance agency that is funded by the federal government, but it's administered by all 50 states. Why is the government getting into the health insurance business? Well, here's what happened. Back then, about 1/3 of Americans were getting their health insurance from their union benefit plans. Union membership was at an all-time high, and if there was a senior family member that belonged to a union, they could get health insurance for themselves and their family members through their union. The other 2/3 of Americans had something called Blue Cross Blue Shield major medical plans. And that system was actually broken up into two parts. There was the Blue Cross part for reimbursement for hospitalization. There was the Blue Shield, which was for reimbursement for all of your other medical. And it was actually two sets of forms. Heaven forbid that you filled out a Blue Cross form to get reimbursement for a doctor visit. They would kick that information back to you and you'd be starting all over again. But that Blue Cross Blue Shield system had been around for a long time, so people were already used to this two-part format, and that's how we got Medicare Part A and Medicare Part B. So let's talk a little bit about Medicare Part A over here on the left. Medicare Part A covers a couple of different aspects of your health insurance. First of all, Medicare Part A has no premium. So long as you worked your 40 quarters and you're entitled to a full Social Security retirement benefit, or you were married to somebody who worked their 40 quarters and is entitled to a full Social Security retirement benefit, you get Medicare Part A at no additional cost. The reason that they had to put in that clause about being married to somebody for 10 years, because it was in 1966 when Medicare was actually implemented, we had this thing called stay-at-home spouses. And there were many, many people who may never have contributed to their own Social Security record. So they needed a way for stay-at-home spouses to get Medicare Part A at no additional premium. So Medicare Part A has no premium, covers hospitalization. Medicare Part A covers hospitalization from the time that you are admitted until the time that you're discharged, so long as that hospitalization lasts longer than 24 hours. So what does that mean? Every doctor, every surgery, every procedure, every test, every diagnostic, every medication, every gurney ride that they're going to charge you for, right, is all covered by Medicare Part A 100%. You have no payment towards your hospitalization. The one thing that Medicare Part A doesn't cover is there is a per hospital admission copayment when you first go through the door. That per hospitalization copayment for 2024 just went up from $1,600 to $1,632. But either way, it really doesn't matter, because why? One of the main reasons you're buying a Medicare supplement plan, this yellow circle down here on the bottom, is all Medicare supplement plans in this area cover the Medicare Part A copayment 100%. So if you're on original Medicare, Part A, Part B, and a supplement plan, between Part A and your supplement plan, if you're admitted to the hospital, your supplement plan is going to pay your $1,632 copayment. Medicare Part A is going to cover everything else for the first 90 days. Yes, right now, somebody in the back of the room would be waving their hand and saying, well, is that forever and ever and ever? No, that's for your first 90 days. There are some additional payments that are required, some co-payments after 90 days. Their 90-day or longer hospital stays represent less than 0.1% of all hospital stays. So we're just going to keep it to the other 99.9%, which says that between Medicare Part A and your supplement plan, you have no out-of-pocket cost. Medicare Part A also covers hospice care. Sometimes as things are winding down, people need some help keeping themselves comfortable in their waning days. Doctors, hospitals, and providers know that if the patient has Medicare Part A, there's no billing to the patient. There's no billing to the patient's family after the fact. So Medicare Part A has no premium, covers hospital and hospice. Medicare Part A covers the smallest amount of long-term rehab, and this is becoming an increasing issue, and it's something I talk about a little bit more in my seminars than I have in the past, because it seems to be coming up more and more. In order for Medicare to pay anything towards a long-term rehab situation, let's say somebody took a fall, they broke a hip, they broke their pelvis, they broke a femur, they had a stroke, they had a heart attack, they're going to go from the hospital to a rehab. In order for Medicare to pay anything towards a long-term care claim, here's what has to have happened. You had to have been admitted to the hospital for at least 3 consecutive days. Within 5 days of discharge, you then have to go to a skilled level nursing home facility, at which point Medicare pays the first 20 days 100%. The next 100 days, you have a $200 a day copayment. After 120 days, Medicare doesn't pay towards long-term rehab. Now, let's talk about this. If you were not admitted to the hospital for at least 3 consecutive days, Medicare doesn't pay. If you don't go to a skilled level nursing home facility, skilled level nursing home is not assisted living. It's not custodial care. It's not intermediate care. It's skilled care, meaning that for the most part, you're probably not ambulatory. You need help transferring out of bed. You need help going to the bathroom. You need help getting dressed. You need help being fed. Those are those activities of daily living that we hear about so much with long-term care plans. If you are not ambulatory, you're now in a skilled level nursing home facility. That is the only level of care that Medicare pays for. So again, if you're not in a skilled level nursing home facility, Medicare doesn't pay. Here's where the problem has been coming in. Hospitals, more and more, have been keeping people overnight and only listing them as under observation. And from what I have been told by participants to my seminars who actually work in hospitals, this is because the hospitals are guarding against rapid readmissions, because it seems that if they have a lot of rapid readmissions, people being readmitted to the hospital in a very short period of time, it actually reduces the rate at which they are compensated from the insurance carriers. So they're all guarding against rapid readmissions. But here is how it's affecting seniors. I got a phone call from a gentleman whose mom took a fall and was in the hospital for 4 days. She was then transferred to a rehab facility for a broken hip, and he was informed immediately that Medicare wasn't paying anything because the 4 days that she spent in the hospital, she was only listed as being under observation. And Medicare only pays if you are admitted to a hospital for 3 days. So the gentleman had called me because he wanted to see where he could file a grievance. And I said to him, let me get back to you and I'll give you some other information. And I spoke to my sources, and here's what we found out. Medicare wasn't going to change anything because the hospital record said that she was only in under observation. The hospital was not reopening up her file because she had already been discharged. So rather than Medicare paying for the first 20 days 100%, and him having a copayment of $200 a day for the next $100 for the next 100 days, he had a $500 a day copayment starting on day one. The reason I bring this up is I am finding out that hospitals more and more and more are keeping people in and listing them as under observation and not being admitted. If you're on Medicare and Medicare is your insurance, and you have a situation where you might need Medicare to pay for a long-term rehab situation, you or whoever your health advocate is for you has to make sure that if you are staying overnight in the hospital, that you're being listed as being admitted. Otherwise, there'll be no benefit for you from your Medicare coverage. So for our purposes, let's talk about the overwhelming majority of time. Medicare Part A has no premium, covers hospitalization 100%, with the exception of the $1,632 copayment, which your supplement plan would pay, and it covers hospice care. Medicare Part B, down here in the red. Medicare Part B is the other half of that Blue Cross Blue Shield model. Blue Cross was Medicare Part A, hospitalization. Blue Shield was all of your other medical. Medicare Part B pays for all of your other medical with a couple of minor exceptions. Medicare Part A doesn't cover routine vision, dental, or hearing. Now, I'm going to clarify that, pun intended. Medicare Part B does cover things like cataract surgery, glaucoma, macular degeneration, detached retina, diabetic retinopathy. Those are all medical conditions of the eye. What Medicare Part B does not cover is routine eye exams, glasses, contact lenses, LASIK surgery, things like that. There is no coverage under Medicare for dental care. There's no coverage under Medicare for hearing coverage. Those things can be purchased as a standalone add-on to your Medicare coverage. So Medicare Part B covers all of the rest of your medical, with the exception of vision, dental, and hearing. So it covers going to your primary. It covers going to your specialist. It covers getting all of your annual checkups from everybody. It covers all of your CAT scans, MRIs, all of your other imaging. It covers all of your other diagnostic procedures. It covers going to the emergency room. When you go to the emergency room, you're not actually being admitted to the hospital. You're just using a very large room on the first floor. That would be a Part B charge. So when you're on Medicare Part A and B, Part B is what covers all of your other medical. Part B has a monthly premium. So again, if you're staying at work, you're staying on your employer-sponsored plan, you're applying for Medicare Part A, so you have that card in your wallet, there is no premium for Medicare Part A. When you then go on Medicare Part B, either at 65 or once you ultimately retire, that is when you'll be assessed a monthly premium. The monthly premium, as we sit here today, is currently $164.90. $164.90, but we've just been given guidance that starting on January 1st, that premium is actually going to bump up to $174.70. So it's actually going up about $9.80. So again, for January 2024, everybody's Medicare Part B premium is going up to $174.70. You know, it used to be back in the day, when you were going on Medicare at age 65, right, you would naturally start to collect your Social Security because your Medicare Part B premium gets withdrawn from your Social Security check. Well, a few years ago, we had a phenomenon occur that had never occurred in the history of Medicare. full retirement age for Social Security became something higher than age 65. And for you people out there that might be 1958 babies, you know that your full retirement age is 66 and 8 months. For you people who were born in 1959, your full retirement age is 66 and 10 months. And for anybody born after 1960, your full retirement age to receive your full Social Security retirement benefit is age 67 or higher. So if you're like many people going on Medicare at age 65, but you're not collecting your Social Security until sometime much closer to age 67, how do you pay for your Part B premium if you're not receiving a check? Very easy. They're going to send you a good old-fashioned paper bill. It's going to have an explanation of your benefits. It's going to tell you what time frame it's covered for, and they're going to do it on a quarterly basis. So $174.70 times 3 is $524.10. You're going to receive a bill for $524.10 every 90 days from Social Security Medicare, and that's for your Part B premium. Everybody pays the same Part B premium. Now, they've actually made it very, very easy for you to pay for that premium. The first thing you can do is, if you like, you can write them a check. Cut off the bottom of the bill that they send you. They send you the windowed envelope, and every 90 days you can remit a check for the $524.10, and that covers your Part B premium. Or, as many people like to do, you can go to Medicare.gov and you could actually pay that bill on your credit card with no service fees and collect your miles and your points. Everybody likes miles and points, don't we? So every 90 days, you're going to get a bill from Medicare for your Part B premium. And then you're going to go and you're going to remit that on your credit card. You're going to get your miles and your points. Just know that once you start to collect your Social Security at any age, that whole miles and points thing is out the window. Medicare is going to take your Part B premium from your Social Security check. The third way, and also an easy way to pay for it, is at that Medicare.gov portal. You can put in your routing number and your account number for your checking or savings account, and then you can have that withdrawn from your bank account on a monthly basis. So not a big deal that you're not going on Social Security and you're going on Medicare instead. There's many ways to pay for that. So Medicare Part A covers hospital and hospice. Medicare Part B covers all of your other medical with a couple of minor exceptions. Medicare Part B has a monthly premium of $174.70. The big exposure in Medicare Part B is it only pays 80% of the bill. So let's talk about this. You going on Medicare for February 1st. February 12th, you have a doctor's appointment. You scheduled that appointment months and months and months ago. Please, 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 when you walk through and go to the check-in at the doctor's office and they hand you the clipboard with that piece of paper on it, and the first thing it says is, do you have new medical insurance? Please say yes. Bring your Medicare card with you and your supplement plan card so that they can take a copy of it and they can bill you correctly. If you don't say yes to that, they're going to try and bill your old insurance, and it's going to create, 6-8 weeks of havoc that you really could have rather avoided. So you go to this doctor's office and you have this appointment, and we're going to say for our purposes that that doctor visit was $500. Maybe it was a checkup with some other diagnostic work done. Medicare Part B is always going to pay 80% of that bill, which is $400. Now there's $100 left over. The main reason that you're buying a Medicare supplement plan, this yellow circle at the bottom, is to pay for the other 20% that you're financially responsible for because Medicare does not cover it. Now, before your supplement plan will kick in, there's an annual deductible. And I'm glad we're here on Zoom because that means most people are probably sitting. The annual deductible for 2024 is now $240. It was $226 for this year. Starting on January 1st, it's going up to $240. So you go to that doctor visit on February 12th. The doctor visit's $500. Medicare pays $400. There's $100 left over. Your supplement plan is going to say, you haven't satisfied your annual deductible yet. You're going to get billed from your doctor's office for that $100. It's going to go against your deductible. But once you satisfy your $240 annual deductible, and your supplement plan kicks in between Part B and your supplement plan, you have no additional out-of-pocket costs for the rest of the year. Now, we're going to put a little bit of meat on the bones here, and I'm going to be quoting some rates based upon the southeastern Pennsylvania area, better known as the five-county area. I know that this is going to be seen in other areas. I just want to give you some information to kind of give you an idea what you should expect and go into the ballpark. If anybody signed in from New York, I apologize right now. New York has a completely different pricing system on their supplement plans, so these numbers won't be anything that are meaningful to you. Again, you'll contact your advisor for that information. But in most areas, most major metropolitan areas, right now, the rates for supplement plans are pretty common, pretty average. Okay, so know that when it comes to supplement plans, that women are a lower cost than men. So for a woman age 65 going on Medicare, what should you anticipate? Well, there's a range of supplement plans that are available. So I'm going to give you the high, the low, and a working average for budgeting purposes. So for a woman age 65, on the high side, you're probably about $150 a month. On the low side, you're at roughly $100 a month. For budgeting purposes, I would say that you use $125 a month. For a man on the low side, you're at about $125 a month. On the high side, you're at about $175 a month. I would use $150 for a man. So Medicare Part A has no premium. Medicare Part B is $174.10. We could call that $175 between us, correct? Then you go to a supplement plan. For a woman, age 65, you're looking at roughly $125 a month. For a man, you're looking at roughly $150 a month. Again, that's for budgeting purposes. We're not taking into consideration any other spousal or household discounts or things like that. I just would rather give you a higher number for budgeting purposes and have your actual number come in lower. So this way we can still be friends. So going on Medicare, at this point, you're roughly at somewhere around $300, $325 a month. Now, we're going to skip around the alphabet a little bit. We're going to come back to Part C plans in a moment, and we're going to jump over here to Part D drug plans. This year in the southeastern Pennsylvania area, there are 26 Part D drug plans, and there is one that is best for you. Starting in 2024, there's only 21 Part D drug plans. And again, there's only going to be one that's best for you. But there's been a lot of changes that have gone on in drug plans, and we're going to discuss that at the end. But if you're currently on Medicare and you are watching this video and you're watching this Zoom meeting, it is more important than ever for you to take advantage of the right that you have to shop for a Part D drug plan right now during open enrollment, October 15th to December 7th, without having to answer any medical questions. The changes in the drug plans for 2024 have been significant and monumental for a lot of people, and we're going to discuss that in more detail at the end. I just wanted you to know that if you're going to go on Medicare, you have Medicare Part A and B. You have a supplement plan to pay for what Part A and Part B doesn't cover. Again, Medicare Supplement, Medigap, they're synonymous. A Medicare supplement plan pays for the gaps in Medicare. Makes sense? And then you have a Part D drug card. Again, in this area in southeastern Pennsylvania for 2024, believe it or not, the lowest price drug card is 50 cents a month for the premium. The highest price plans that we're seeing are somewhere around $112 to $125. A good working average for budgeting purposes, I would say, is $25. So if you're going on Medicare, age 65 in this area, again, for a man, A, B, a supplement, and D, you're somewhere in the area of $325 to $350. And for a woman, you're somewhere in the area of $300 to $325 a month. The only additional financial exposure you have on Medicare over and above the cost of your premiums is your $240 annual deductible and the cost of your medications at your favorite pharmacy or through mail order. That's it. That's it. That's original Medicare. A, B, a supplement, and D. Now, because nobody's asking me a question, I'm going to take a sip of water without you. So Remember those insurance carriers in the 60s that used to discriminate against seniors and force them to go through medical underwriting, which is what forced Medicare to be created in the first place? Because what would happen is people would leave their employer-sponsored plans. They weren't able to buy health insurance at rates that they can afford. So they would go into their retirement years with no health insurance. One of them would have a significant medical event and wipe out all their savings. That's really why Medicare was created. Well, those health insurance companies back in the 1960s reconstituted themselves in the late 1970s and the early 1980s and now became managed care plans. Major medical plans went by the wayside. And when these carriers came into existence to create these managed care plans, we've known them for the last 40 plus years as HMO plans and PPO plans, but they are considered managed care plans. They are managing your care. When these plans first come into existence, they start off as employer-based insurance only. They are group plans for employers to help employers manage their employees' health insurance plans. Then they're allowed to sell to employees once they leave their group plan and they could continue their coverage. Then these carriers are allowed to sell to individuals. The one group of individuals they weren't allowed to sell to were people who were Medicare eligible. So again, these carriers are coming into existence in the early 1980s. By the time we get to the early 1990s, they realize that they are losing 100% of their subscribers either at age 65 or over 65 when they leave their employer-sponsored plan. So what do? They go to Washington. They talk to their friends. They have a conversation. Hey, why don't we give people on Medicare more choices? Why don't we do a public-private partnership between Medicare and the insurance industry to allow for more choices? And in 1998, Congress passes a law allowing private health insurance companies to sell private health insurance plans to people who are Medicare eligible, and it's called Medicare Choice Plans. Those Medicare Choice Plans are now called Medicare Advantage Plans. So, your spouse knew when you were turning 64. Your children probably knew when you were turning 64. Your grandchildren, maybe your nieces and nephews had no clue. Your neighbors definitely didn't know, but the health insurance industry sure knew when you were turning 64 because they've been sending you between 20 and 50 pieces of direct mail every single month since you turned 64. And heaven forbid somebody got a hold of your phone number, you've now notified the rest of the family that you no longer answer the house phone between 5 o'clock and 7 o'clock at night because it's always solicitations from people wanting to solicit your Medicare business. About 75% of that mail that you've been getting is for something called a Medicare Advantage plan or a Part C plan. So Part C, Medicare Choice Plans, Medicare Advantage Plans came into existence in 1998. That's how they became Part C. Part D drug plans don't come into existence until 2006. That's how they became Part D. A Medicare Advantage plan, is a private health insurance plan sold by a private health insurance carrier to somebody who is Medicare eligible, and it replaces Medicare. Let me say that again. A Medicare Advantage plan is a private health insurance plan, comes in the two standard flavors in this area, HMO and PPO. It's a private health insurance plan sold by a private health insurance carrier to somebody who's Medicare eligible, and it replaces your Medicare. It does not coordinate with your Medicare. When you go to a Medicare Advantage plan, you are no longer on Medicare. What does it mean to say that you're on Medicare? When you're on Medicare, A, B, a supplement, and D, your doctors and hospitals and providers are submitting claims for your care to Medicare. Medicare is actually paying those claims. When you go to a Medicare Advantage plan, those claims are being presented to a private health insurance company, and that private health insurance company is responsible for paying your claims. That's why you're no longer on Medicare. You're getting 100% of your Part A and Part B benefits from a private health insurance carrier. You're no longer on Medicare. So, what are some of the advantages of a Medicare Advantage plan? Well, almost all Medicare Advantage plans offer some level of vision, dental, and hearing coverage. So if vision, dental, and hearing coverage is important to you, you might want to consider a Medicare Advantage plan. A lot of them do offer gym memberships where you can go to the gym as part of your plan, and the plan either has a small additional stipend or it's actually included in the plan where you have gym memberships. Many of them have things like a monthly or quarterly stipend for your over-the-counter medications at their preferred pharmacy. So your aspirins, your allergy medications, your antacids. No, you can't get the branded version, but all of these plans have relationships with pharmacy chains, and you're going to get the pharmacy version of the pharmacy branded version of your over-the-counter medications. And they may offer you a, $30 a month, $60 a quarter stipend towards those medications as well. These plans all have the same number in all of their advertising. Get your health insurance for as low as $0 a month. And I'm here to tell you, there is no $0 plan. There is no truly $0 plan, because here's why. Whether you're on original Medicare, Part A, Part B, a supplement, and a drug card, or you disenroll from that channel and you go to a Medicare Advantage plan, either way, you're paying the Part B premium. Everybody pays the Part B premium, again, in January, going to $174.70. Did I say $174.10? $174.70, starting on January 1st. So essentially what's happening is your Medicare Advantage plan is the premium, that $0 premium is replacing the premium that you'd be paying for your supplement plan. And in this area, almost all the plans in this area come with a Part D drug card built right into it. So you have one Part D drug card in your Medicare Advantage plan. So again, Medicare Advantage plans are a private health insurance plan sold by a private health insurance carrier to somebody who's Medicare eligible, and it replaces your Medicare. These plans start as low as $0 a month. But the lower the premium, the higher the deductibles and the copayments. Remember what we said before, when you're on original Medicare, A, B, a supplement, and D, once you satisfy your annual $240 deductible, what's your out-of-pocket cost? The cost of your medications at your favorite pharmacy or through mail order, and that's it. Everything else is covered throughout the rest of the year. You have no other copayments. On original Medicare, yes, you can get a plan that starts as low as $0 a month, and first of all, referrals are pretty much off the table. Nobody requires referrals anymore. And typically, your annual checkup at your doctor is covered 100% where there's no copayment on it. But if you're taking anything for cholesterol, or blood pressure medication, or any other, abnormality, what is your doctor going to say to you? I want to see you back here in 90 days. I want to see you back here every 6 months. When you go back for that follow-up visit is not your annual. So there's going to be a copay to go see your doctor for your follow-up. There's going to be a copay to go see a specialist. You can have a copay down here to get an x-ray, but you can have a copay up here to get an MRI. You can have a copay for the ambulance ride to the emergency room, and you can have a copay for everybody who you saw in the emergency room who's going to bill you. So as you can see, the way that a Medicare Advantage plan makes up the difference is you're paying copays and deductibles. Again, if you have an HMO plan, and again, Medicare Advantage plans come in the same standard 2 flavors of HMOs and PPOs. If you have an HMO plan, that plan means that you have to receive 100% of your care from an in-network provider. If you go out of network, you pay that bill 100%. On a PPO plan, you can go in-network or out of network, provided that that carrier or provided that that doctor, hospital, provider can bill the insurance company. But typically what happens is you have to then satisfy a higher first dollar deductible before the plan will kick in. And then the percentage of the bill you have to pay is going to be higher than going to an in-network doctor. So what's the advantage to Advantage plans? Well, here's the thing. I find that there are 3 groups of people that are interested in Advantage plans. The first group of people, do-it-yourselfers, people who are not here. Understand there are 10,000 people a day, 70,000 people a week going on Medicare. And those people all have to make a choice. And where are they getting their information from? They're getting partial information. They're getting information from their older siblings. They're getting information from their older neighbors. They're getting information from the internet. They're getting partial information. They don't realize that there are two distinct channels for providing health insurance for people over 65. One is called Original Medicare, and the other one's called a Medicare Advantage Plan. So the first group of people that I find are interested in Medicare are people who don't understand that there are two distinct channels. When you go on Medicare Part B for the very first time, either at age 65 or over age 65 when you leave your employer-sponsored plan, when you go on Medicare Part B for the very first time, that is your one and only opportunity to buy any supplement plan or any advantage plan that's available in your area, and they cannot ask you any medical questions. Once you've been on Medicare Part B for 6 months or longer, if you want to make any changes to your supplement plan, either take your supplement plan and buy the same plan from another carrier or buy a different plan inside of your carrier's offering, they're going to make you medically qualify. They're going to make you medically qualify. On a Medicare Advantage plan, you don't have to medically qualify. You have to medically qualify to buy a Medicare Advantage plan. You only have to wait for one thing: open enrollment, October 15th to December 7th. Any year you want, you can go from Original Medicare to a Medicare Advantage plan. During open enrollment, that plan will become effective on January 1st, October 15th to December 7th. And if there is a plan that starts at $0 for a 65-year-old, there's a plan that starts at $0 for an 85-year-old. They just know that if that 85-year-old is in less, in not a good health condition as a 65-year-old, that they're going to make up for it on all of the deductibles and the copays. So on a Medicare Advantage plan, the first group of people that I find that are interested in Medicare Advantage plans are people who, don't understand that there are two different channels for providing health insurance. Right about now, somebody in the room would be saying to me, so if I go to a Medicare Advantage plan, can I go back to Original Medicare? And the answer, quite honestly, is yes, maybe. And here's why. As I just said, you have one opportunity to buy a Medicare supplement plan with no medical underwriting. One. And that's when you first go on Medicare Part B, either at age 65 or over 65 when you leave your employer-sponsored plan. If you go to a Medicare Advantage plan and you're there for longer than 1 year and you want to go back to Original Medicare, you can notify your Advantage plan during open enrollment that you're going back to Original Medicare. But if you cannot answer the medical questions to buy a supplement plan, and you're then going to be financially exposed to paying out of pocket for 20 cents on the dollar for all of your medical bills and 100% of your copayment for all your hospitalization admissions, are you going to? Probably not. Probably not. You're going to stay in the Advantage plan world. And that is one of the biggest things that people don't understand. People say to me all the time, you mean to tell me that there's no secondary opportunity to buy a supplement plan with no medical underwriting? Correct. There is one initial enrollment period, and that's when you first go on Medicare Part B. Again, you can always go to an Advantage plan. Open enrollment, the term open enrollment literally means no health questions, no medical background. That's what open enrollment means. You can make a choice with regard to your health insurance coverage without having to answer any medical questions. If you're staying on Original Medicare, A, B, a supplement, and D, during open enrollment, the only moving piece that you have during open enrollment is your Part D drug card. Yes, you have the right to shop for a new Part D drug card during open enrollment, October 15th to December 7th, every year you want, and they cannot ask you any medical questions. If you're on a Medicare Advantage plan, you can go from your Medicare Advantage plan to a different Medicare Advantage plan during open enrollment. That new plan becomes effective on January 1st. They cannot ask you any medical questions. Open enrollment literally means no medical underwriting. First group of people I find that are interested in Medicare Advantage plans are do-it-yourselfers, people who don't understand that there are two channels. The second group of people that I find that are interested in Medicare Advantage plans, people who have been on Medicare for a while. and here's why. Your Medicare supplement plan, as I said earlier, for women, we're going to use $125 for budgeting purposes. For men, we're going to use $150. But those plans tick up every single year as you get older. And depending on which plan you have, some of them actually go up faster than others. So you might start off at $125 at age 65, but now when you get to age 80, you might be closer to $200 or $225. And when you get into your 80s, those rate increases tend to be higher. So maybe now you're in your mid 80s. And maybe that retirement nest egg isn't as fluffy as it was back when you were 65. Maybe you're not flying anymore. Maybe one of you is not flying anymore. The grandkids are coming to see you more than you're going to see the grandkids. Understand that original Medicare, A, B is supplement, and D is the only health insurance program we have in this country that has no network. Has no network. All 50 states and US territories. There is no in-network or out-of-network when you're on original Medicare. All Medicare Advantage plans use networks as a way to do what? As a way to guide and corral you to who? Their preferred providers. You want to keep your health insurance costs as low as possible? You have to go to our in-network providers. All Medicare Advantage plans use networks as a way to do what? Limit their cost. What's the biggest cost to a health insurance company? Paying your medical bills. Let's talk about some other comparisons. Original Medicare, as we said before, hospitalization, right, has no copayment on original Medicare. Between Part A and your supplement plan, hospitalization is covered 100%. If you have a $0 Medicare Advantage plan, you might have a $200, $250, $350 a day copayment for up to the first 10 days. If you have a $250 copayment and you end up in the hospital for 8 days, that's $2,000 out of your pocket. So again, first group of people interested in Medicare Advantage plans, people who are, do-it-yourselfers, don't understand. The second group of people who've been on Medicare for a while and they need to reduce their fixed cost. Again, having the national network, having all those other bells and whistles be nice, but they're going to go ahead and get an HMO plan or a PPO plan, and they're going to try and get a plan for as low as $0 as they can, but a lot of times they can't do that. So the second group of people are people who are looking to reduce their cost. The third group of people who are interested in Medicare Advantage plans, quite honestly, there are a lot of people. According to Fidelity Investments, 90% of all Americans have saved less than $100,000 in their retirement account. That's not to say that they're worth less than $100,000. Maybe they have money in their equity in their home and they have other investments and things like that. But if you go back a few generations ago, people retired on their Social Security and their pensions. Pensions were replaced by retirement plans. If 90% of Americans have saved less than $100,000 in their retirement plans, that means they don't have a pension and they really don't have an income stream coming from their retirement plan. So most people are living on their Social Security. We know that the average Social Security check for an individual has now risen to about $1,800 or $1,900. But the average household Social Security for a couple who are married and filing jointly is somewhere around $3,500 a month. They're not both getting that $1,800. And understand, whether you're on original Medicare or Medicare Advantage plan, everybody's paying that Part B premium. And now that Part B premium is up to, we'll call it $175 a month, right? That means that for a husband and wife taking in $3,400 a month from Social Security, Medicare Part B is taking almost 10% of their check. And as much as they would love to have a Medicare supplement plan and a drug card, maybe going to a Medicare Advantage plan is the right move for them. Maybe vacation kind of looks like a couple of weeks up at the mountains or a couple of weeks down the shore, but they know that they're going to be in their immediate service area, 95, 98, 99% of the time. My role here is not to tell you what's better or worse. My role here is basically just to tell you the implications of making one decision over another. There are two distinct channels for providing health insurance for people over 65. One is called Original Medicare. The other one is called a Medicare Advantage plan. Here's some other differences you need to know about Medicare Advantage plans. In addition to using networks, Medicare Advantage plans all reserve the right and will use pre-authorizations and pre-certifications as a way to limit the care that you are looking to get. If you're on original Medicare, A, B, a supplement, and D, there is no pre-authorization and pre-certifications. There is no pre-authorizations and pre-certifications. Many times people get fed up and they want to go back to original Medicare because they're not getting the care they need, because they're getting caught up with their insurance carrier on pre-authorizations and pre-certifications. But unfortunately, now that they're receiving that level of care, they can no longer medically qualify for a supplement plan, so they have to shop for another more comprehensive Medicare Advantage plan. The last few things about Medicare Advantage plans I'll tell you is this. They all come in this area with a Part D drug card built right into it. And if for whatever reason your medications change and your Part D drug card is no longer as effective as it was, and you need to change Part D drug plans and you're on an Advantage plan, well, guess what? You can no longer buy a secondary Part D drug plan and plug it in there. You have to use the drug plan that comes with your plan. And if you need to change the drug cards to lower the cost of your prescription medications, you have to change your entire Medicare Advantage plan. You have to make sure that because you're now lowering your prescriptions, that your primary hospital is in there, that all your doctors are in there, all your specialists are in there, all of the places where you do all of your diagnostic work are all in network, because you're doing it to control your cost. My role here, again, is not to tell you what's better or worse. My role here is to help you understand that there are two distinct channels for providing health insurance for people over 65. One is called Original Medicare, and the other one's called the Medicare Advantage Plan. Now, we're not taking questions, so I'm going to go directly to a story about Jack from Jack's Auto, because I want to let you know that when it comes to Medicare, you've got to do what you got to do when you got to do it. So we're going to talk about Jack from Jack's Auto. Jack was that guy in high school that used to turn wrenches in the shop while you were in class studying to go to college. And when you went off to college, Jack went to go to work for Jim at Jim's Auto. And by the time Jack was 25 years old, he was making more money than all of his friends who had gone to college, turning wrenches at Jim's Auto. But as Jack got into his late 20s, Jim decided to retire, and Jack bought Jim's Auto. The automobile repair business, became something a whole lot more than it had been for decades and decades. And Jack had to expand Jack's Auto. And Jack actually built out his building, and he had 3 different bays, and he had technicians, and he had all this technology. And he had to get health insurance for himself and all his employees. Otherwise, he wouldn't be able to retain his best help. Jack got married sometime in his 50s. Jack got divorced. Now Jack is 64 years old, and Jack sells Jack's Auto. When Jack sells Jack's Auto, he's no longer part of the group plan that was with Jack's Auto, and he goes out into the exchanges and finds out that if he wants to buy health insurance that's somewhat near the quality of health insurance he had under his group plan, it's going to cost him about $1,000 a month. Jack says, heck with that. I don't ever go to the doctor. And he doesn't buy any health insurance. Now Jack's getting all that direct mail that you're getting, and he's like, you know what? I'm not going on Medicare. I'm going to self-insure. I'm going to save them money. And Jack doesn't sign up for Medicare Part A and B. He's just going along with his life and having a good old time. Now Jack's 68 years old, and he's having a little trouble catching his breath as he's going up the stairs. So he finally decides to go to the doctor and get a checkup. And the doctor does an EKG and comes back in and says, you know what, I think I need to send you to a cardiologist. I see some things here that, are outside the scope of what I do, but I think you need to see a cardiologist. And Jack says, hold that thought. I don't have any health insurance. I'm paying cash for all this. What do you think it's going to cost me to go to see a cardiologist? He said, well, it's not just going to see the cardiologist. It's doing all the testing that they want to do and possibly doing the treatment they want to do. And if you have to go on a medication like a Xarelto or an Eliquis or something like that, that medication is like $600 a month. Jack says, hold that thought. I'll be right back. And he goes outside and he gets in his car and he gets on the phone to Social Security. And he says, hi, I would like to sign up for Medicare. And they said, great. When do you turn 65? He said, 3 years ago. Voice on the phone says, 3 years ago, where have you been? He said, I've been self-insuring. I've been saving you money. Right? They said, no, you haven't. You haven't been paying into the system. Jack says, okay, fine, whatever. My doctor wants me to go see your cardiologist. I need health insurance. Right? They said, great. Call us back in January. Call you back in January. Why do I have to call you back in January? Well, you got to do what you got to do when you got to do it. And you didn't sign up for Medicare when you turned 65. So now you have to wait for the general enrollment period, which starts on January 1st and runs through March 30th. Jack says to the person on the phone, you're telling me now in the middle of October that I can't get health insurance until January? And the voice says, no, we're telling you that you can't sign up for health insurance until January. That coverage doesn't go into effect until July 1st. So now Jack is sitting here in October of 2023, and he's not going to have health insurance coverage until July of 2024. In his exasperated breath, Jack says, okay, fine. What other good news do you have for me? They said, well, because you didn't do what you got to do when you got to do it, you're going to have to pay a late enrollment penalty. Jack says, I got to pay a late enrollment penalty. How much is my late enrollment penalty? Well, you're going to have a late enrollment penalty on your Part D because you didn't get your Part B when you first supposed to sign up. And you're going to have a late enrollment penalty on your drug card once you pick up a drug card. The late enrollment penalty for your Part B works out to about $15 for every year that you're late. By the time your coverage kicks in July, you're now going to be 69 years old, which means you're going to be 4 years late. 15 times 4 years is about $60 a month for late enrollment penalty. Your drug card works out to about 35 cents a day or about $4 a year, 4 years late. You're going to have somewhere in the neighborhood of about a $75 to $80 late enrollment penalty. Jack's like, okay, so I got to pay the late enrollment penalty for 4 years because I was late for 4 years. And the person says, no, you have a monthly late enrollment penalty for the rest of your life. The moral of the story is, when it comes to signing up for Medicare Part B and Part D, you got to do what you got to do when you got to do it. And now that you've heard this little tale, you can't say you don't know Jack. Let's see what's going on here. We're currently insured through, okay. So I have a message from an anonymous attendee. I didn't know you could do this. What I would suggest is that you contact your financial advisor and they will forward that off to me. We're not doing questions and answers in the midst of this seminar, but thank you very much. And I apologize for not being able to take your questions in this format. So that's the difference between original Medicare and a Medicare Advantage plan. I would normally say, does anybody have any questions? But we're not doing questions and answers in this format. So we're going to turn the page. This page here is just a little bit more about Medicare Advantage plans. Again, we've covered a lot of this ground already. As you can see here, right from the top, it says sold by private health insurance carriers, replaces original Medicare. It's health insurance managed by an insurance company. You know what? If your doctor says, I suggest that we do this, but your health insurance company says, well, we're not going to authorize that, are you really even in the conversation? Are you really even, making your own medical decisions? No, a computer is through a health insurance company. When you're on original Medicare, there is no pre-authorizations and pre-certifications. So something else to really consider. As we said before, these plans typically come in 3 different pricing buckets. There's a $0 to $20 bucket, the $25 to $75 bucket, and the $100 to $200 bucket. Why are there more expensive plans? Because people need plans that either have a larger network, lower co-payments, more providers, whatever the case may be. So will these slides be shared with attendees? Very helpful, and thank you for sharing your expertise. Yes, we will send this slide presentation out to everybody at the end. Okay. So again, I'm not going to belabor the point on Medicare Advantage plans. I'm just going to say this one last thing. The good news is that for all these deductibles and co-payments that you would now have when you go to an Advantage plan, there's an annual cap. If you're receiving care in a HMO setting, meaning that you're receiving care from an in-network provider, that annual cap is $8,300. If you're receiving care in a PPO environment, maybe you had to go to a hospital in a special, outside of your immediate coverage area, and you're now utilizing your PPO benefits, your out-of-pocket expense could be as high as $11,300, and that resets on January 1st. So again, it's not a lifetime thing. It's not it's not a per event thing. It's an annual out-of-pocket expense, cannot exceed $11,300, where on original Medicare, your out-of-pocket expense is the cost of your premiums, your $240 annual deductible, and the cost of your medications through your favorite pharmacy or through your networks. And then we're going to turn the page to supplement plans. So, supplement plans. Here's some things you need to know about supplement plans. First of all, they're designed by the federal government. That's a very good thing, because what a Plan G does in Pennsylvania, a Plan G does in New Jersey, a Plan G does in New York, a Plan G does anyplace else in the country. They're nationally standardized plans. They're sold by private health insurance carriers. But unlike a Medicare Advantage plan, these health insurance carriers have no say-so in your medical decisions. These supplement plans are there to be a financial tool to pay for the financial exposure you have for being on Medicare. That financial exposure is your Part A per admission copayment and the 20% that Part B doesn't cover. So if your doctor says you need to have a knee replacement and it's medically justified and you're on original Medicare, and Medicare pays the 80%, your supplement plan cannot say, we didn't think that was necessary. We're not paying the Part B. It doesn't work that way. They're along for the ride. So again, these plans are designed by the federal government, which means they're standardized across the states. They're sold by private health insurance carriers. But again, these health insurance carriers that are selling these plans have no say-so in your medical decisions. But all plans are not sold in all states, and not all carriers are available in all states. So if your sister who lives in New Mexico has a Plan G from Corn Cob, Nebraska, but Corn Cob, Nebraska is not available in the state where you live, then you cannot buy a Plan G from Corn Cob, Nebraska. You have to buy a Plan G from another carrier. They say in all the books that there are 10 supplement plans to choose from. I'm here to tell you that better than 99% of the time, there's only 2 for you to choose from. And here's why. As you look down the left-hand side here, all these rows here represent coverages that your Medicare supplement plan would cover. If there's a check mark in it, it's covered 100%. If there's a yellow box in there, it's not covered at all. Now, unfortunately, I had not had an opportunity to update these slides. So as you see here, the Part A deductible where it says $1,600, right? It's actually $1,632 as of January 1st. The Part B deductible that says $226, that's going to $240 as of January 1st. So you'll make those little notations when you get your set of slides. Some of these plans pertain to parts of the country that are receiving other federal economic aid, so they're not available in your area. Some of these plans pertain to people who were on Medicare due to Social Security disability and on Medicare, and then are coming up employer-sponsored plans. I can tell you right now that if a carrier is selling in your area, they're going to be offering 3 of the 10 plans. Those plans are Plan F, Plan G, and Plan N, or the ones that we've highlighted here in blue. Now, as you look down each one of these columns, each column represents a plan of coverage. Some have check marks in it, some have yellow boxes in it. The first thing you might notice is that Plan C and Plan F are out of order. We'll talk about that in a moment. And Plan H, I, and J are missing. So what happened to H, I, and J? H, I, and J were the first supplement plans that had prescription drug coverage. When prescription drug plans came into effect in 2006, all plans that sold prescription drug coverage were discontinued. So that's what happened to H, I, and J. What happened to Plan C and Plan F? Well, Plan C and Plan F were the only 2 plans that had a check mark down here that paid the Part B deductible. Back in 2015, Congress was having a discussion about the reauthorization of the Children's Health Insurance Program known as CHIP. One side wanted to vote to reauthorize it. The other side said, we're not going to vote to reauthorize that unless you show us some ways to offset the cost of the program. So in the compromise, they came up with this. If you are not Medicare eligible for Part A prior to January 1st of 2020, meaning that you were born after 1954, If you were born after 1954, you were not Medicare Part A eligible prior to January 1st of 2020. You can no longer buy a supplement plan that paid the Part B deductible. So Plan C and Plan F went out the window. Now, as you look over here at Plan Fs are the most popular plan in the country. If you talk to anybody who's 70 and over and they're on original Medicare, the overwhelming majority of the time, they're going to be on a Plan F. And what they're going to tell you is, I don't pay anything to go to the doctor. And it's true. They have no deductibles. They have no annual copays. Plan F paid for everything. But what they do have is a very, very, very high bill. And here's why. When they shut off the ability for younger, healthier 65-year-olds to go into Plan F starting in January 2020, that pool of insureds, remember we talked earlier, you cannot readily move from one plan to another. You have to medically qualify to move from one plan to another. That group of insureds started to get less younger, healthier people in it. So that group just got older and statistically less healthier. Then in 2020, that first round of rate increases came into play for a group that was statistically older and less healthier, and the rate increases jumped up. And what do you think happened in 2020 and 2021? All the people who had Plan Fs who were healthy, they left and they bought a Plan G. Because as you look over here at a Plan G does everything a Plan F does, except it doesn't pay that $240 deductible that we already spoke about. So everybody who was healthy in Plan F left Plan F to reduce their premiums significantly and went to a Plan G. Now, Plan Fs are experiencing something that they call in the insurance industry adverse selection. The group of people who have Plan Fs are statistically significantly older and statistically significantly less healthy than every other plan on the page, simply because of the fact all the healthy people left that plan. The only option that people have on Plan Fs to reduce their premium is to, during open enrollment, go to a Medicare Advantage plan. Because again, you can always go to a Medicare Advantage plan during open enrollment. Open enrollment means no health questions. You can always go to an Advantage plan with no health questions, or you can stop being on Medicare for the obvious reason. And that's it. Those people are stuck. So, like I said, there are 10 plans on the page, but there's really only two the overwhelming majority of you are going to consider: a Plan G and a Plan N. So let's look at a Plan G. A Plan G does everything that a Plan F does, except pay the $226, soon to be $240 annual deductible. So whether you're going to your doctor, you're going to your specialist, you're going to the hospital, right? Hospitalization is covered right here. The Part A deductible is covered. You see there's a check mark in there. Everything is covered by Plan G. And Plan G right now is the most popular plan in America. It is without a doubt the most popular plan in America. But because you've come to my seminar and my educational workshop, I want you to seriously consider looking at a Medicare Plan N. And here's why. A Plan N is a Medicare supplement plan. You are still on original Medicare. But in this area, in southeastern Pennsylvania, on average, Plan Ns are between $500 a year and $600 a year, less expensive than a Plan G. That's number one. Now you're saving $500 or $600 a year in premium. Why is it less expensive? Well, you're getting less benefit. If you go onto a Plan N, you now have up to a $20 copay every time you have an office visit with a doctor. So that $20 doesn't pertain to going and getting your testing done. It doesn't pertain to getting your imaging done. It doesn't pertain to occupational therapy or physical therapy. There's no co-payments for that. It's when you go to see a doctor. Well, if you're saving $600 a year in premium, but you have to pay up to $20 every time you go to the doctor, you'd have to go to the doctor 30 times a year before Plan N first starts to become less cost-effective than a Plan G. So a Plan N is less expensive because you have a $20 copay. But if you're like many people that I meet, and on a bad year, you're going to the doctor 4 times, 5 times, 6 times, and you have to pay a copayment 6 times, well, if you're saving $600 a year in premium, but you're paying $120 a year in copayments, who's saving the other $480? You or the insurance carrier? So now here's a way for you to be on original Medicare, keep more of your healthcare dollars in your pocket. You also have a $50 copay if you go to the emergency room. This plan, like every other plan, does not kick in until after that first $240 annual deductible is met. This plan also has a second yellow box. That second yellow box is something called a Part B excess charge. In 42 out of 50 states, doctors, hospitals, and providers are allowed to charge you up to 15% more than they were reimbursed from Medicare. The 8 states that do not allow for Part B excess charges are down here below: Connecticut, Massachusetts, Minnesota, New York, Ohio, Pennsylvania, Rhode Island, and Vermont. So if you're watching this seminar and you're in one of those 8 states, do you care whether or not your supplement plan pays for Part B excess charges? No, because in those 8 states, they're not allowed to charge it. So again, you're saving money on your premium, and you're still on Medicare, and you don't have to worry about Part B excess charges. But let's say you end up in Ocean City, New Jersey, or Ocean City, Maryland, or Los Angeles, California, and you end up in the emergency room. The emergency room is a Part B charge. On a national basis, less than 5% of doctors, hospitals, and providers that accept original Medicare excess bill. So if you go on a plan N and you're outside of one of those 8 states, the likelihood of you being excess billed is very, very slim. Again, my role here is not to tell you what's better or worse. My role here is to tell you the implications of making one decision over another. Here's something else you really need to consider. The overwhelming majority of Americans are going into Plan Gs, and we could have a 2-hour discussion as to why that is. Plan Ns, for the most part, are underutilized, and most people don't learn about that. Again, if you're doing this on your own and you're looking at mom and dad's card and they had a Plan F, and you're talking to all of your older friends who are in their 70s and 80s and they all have a Plan F, and you find out that you can't buy a Plan F because you were born after 1954, but you could buy a Plan G, well, then you just go and buy a Plan G, but you're not completely informed. You didn't go to Steve's seminar. What can I tell you? Here's the other thing. In the past year, Plan G rate increases have been going up in the high single digits. Plan N rate increases have been going up in the low single digits. If I roll back the clock just 3 years, the difference between an average Plan G and an average Plan N was about $300, or roughly 15 visits a year. Now here we are going into 2024, and the difference between a average Plan N and an average Plan G is about $600. Now you're up to 30 visits. If these rate increases keep going where Gs are going up at a faster rate than Ns, I guarantee I'll be sitting here 2 years from now telling you that the difference between a Plan G and a Plan N is 45 visits or $900 a year. Because again, it's based upon utilization that these carriers go ahead and file for rate increases. One other thing, if you happen to have an adverse health outcome, your carrier cannot raise your rate on just you because you have a higher utilization. If you're getting a rate increase from your carrier, that means they filed with the state insurance commission where your plan is. That state then approved that rate increase, and that rate increase goes into effect for everybody in your service area. So they can't raise your rates simply because of the fact that you've had an adverse outcome. So again, there's really only 2 plans to consider. Remember, I gave you that range before. Well, the Plan Ns are the one on the lower side of that range. And again, we haven't even calculated in living with somebody or household discounts for when both spouses come on, which can be very, very considerable in lowering those prices. And that's what we have in Medicare supplement plans. Can't ask you if there's any questions, so we're just going to move forward from there. We're going to finish up now on Part D drug cards. And I have to tell you, as I said before, the Inflation Reduction Act of 2022, all I've heard about on the news, the most significant investment in climate change ever. The Inflation Reduction Act of 2022, the most significant investment in climate change ever. Well, I'm here to tell you, the Inflation Reduction Act of 2022 was probably the most significant piece of legislation for Medicare recipients in over 2 decades. And why they're not crowing about this is beyond me. And here's why. Starting in 2024, all your plans are built the same way. They always have been built the same way. They take the entire universe of medications that are out there and they create something called a formulary. A formulary is a list of the drugs that they're going to cover. Every plan has to have at least 2 medications in every therapeutic category. Those categories of medications are then put into a tiering system. So tier 1 are your preferred generics. Tier 2 are your non-preferred generics. Tier 3 are your preferred brands. Tier 4 are your non-preferred brands. Tier 5 are your specialty medications. Some plans have even instituted a tier 6 for insulin-based products. Typically, on most plans, your tier 1 preferred generics are somewhere between $0 and $3 a month. Your tier 2 medications are somewhere between $3 and $10 a month. Your preferred brands, your specialty medications, your preferred brands, your non-preferred brands, and your specialty medications are subject to higher copayments. All plans are allowed to charge a premium. As I said, in southeastern Pennsylvania for next year, the lowest price plan is 50 cents. The highest plan is roughly $125. Again, every plan has to have at least 2 medications in every therapeutic category, but it's where they put all of the other medications in the tiering system that weighs one plan towards one certain group of drugs or another. So if all you're taking is a handful of generics, maybe you're taking a little atorvastatin for your cholesterol, or a little pravastatin, or a little rosuvastatin for your cholesterol. You're taking a little valsartan or a little lisinopril for your blood pressure. Maybe you're taking, a little levothyroxine for an underactive thyroid. You're taking medication for type 2 diabetes to help reduce your A1Cs. Again, all those medications are typically tier 1, tier 2 generic medications. But it's when you get into your preferred, your non-preferred, and your preferred and your specialty medications that this chart really kicks in. Because your plan can have a premium. The premium, again, in this area is as low as 50 cents, as high as roughly 125. Your plan can have a deductible. Your plan could choose to have a 0 deductible, or it can have a deductible that can't exceed $545. But if all you're taking is a handful of generics every month, and between your 4 medications, your out-of-pocket cost is $11 a month. At $11 a month, you're never getting to $545. You don't care that your drug card has a $545 annual deductible. You're never getting there. That $545 is against the retail price of primarily your tier 3, 4, and 5 medications. So let's say you're taking a handful of generics, and then your doctor has to put you on a blood thinner like a Xarelto or a Eliquis. Those medications are typically roughly $600 a month. So what's happening here is there's a ledger running with the total retail price of your medications. If your card has a $545 annual deductible and you now get put on Eliquis, well, you're going to have to satisfy that $545 before your plan will go down into the cost sharing. Once you get to the cost sharing, you're going to pay the lesser of 25% of the cost of that medication, or a fixed price of $47. But again, there's a ledger running with the retail price of your medications, all of your medications. So let's say the retail price of your generics and your retail price of your Eliquis is $700 a month at retail. Well, sometime in and around the 7th or 8th month, the cumulative retail price of your medications is going to exceed $5,031, and then you're going to move down into that thing called the donut hole, which they've been talking about getting rid of forever, and they haven't done it so far. What happens in the donut hole is all of your medications get repriced, including your generics, and a greater percentage of the cost of the medication gets kicked back onto who? You. And you're going to be in the donut hole as long as the cumulative retail price of your medications does not exceed $11,477, or your cumulative out-of-pocket cost doesn't exceed $8,000. Here is where this new law that came into effect in 2022 is affecting Medicare recipients the most. What they have done is there used to be a copayment of 5% on catastrophic coverage. Once your out-of-pocket cost exceeded $7,500, now $8,000, or the cumulative retail price of your medications exceeded $11,477, right? You used to have to pay a $5 copay. For many people out there that may be on a biologic, maybe they're on a Humira or a Cosentyx, maybe they're on an outpatient chemotherapy, right? They're on something like a Revlimid, right? Or even worse, a Jakafi. Or there are other biologics out there like Stelara, right? Jakafi is $37,000 a month. Stelara is $25,000 a month. Revlimid is in the tens of thousands. Humira and Cosentyx are $7,000 or $8,000 a month at retail. So for somebody who's on an outpatient chemotherapy, they retail price of their medications, they may have a retail price of their medications that's $15,000 in the first month. I met one person at my seminar. She's on a medication called Jakafi. It's $37,000 a month. It's an outpatient chemotherapy. It's $400,000 a year for her medication. On her Medicare supplement plan, on her Part D drug plan, and her copayment for this year, her out-of-pocket cost was $19,000, because 5% of $400,000 is about 20 grand. The cost of her plan plus the cost of her medications was almost $19,000 this year. Under the Inflation Reduction Act of 2022, and them doing away with the copayment in the catastrophic phase, the cost of her medications next year are going to be under $3,500. Under $3,500 from 20 grand. It is the most significant piece of legislation for Medicare recipients. It was signed in 2022. For 2023, it reduced insulin and all insulin-based products down to no more than $35 a month, no matter how many units of insulin that you were using. For 2024, it's doing away with the copayment in the catastrophic. And for 2025, everybody's shopping for their drug cards this year, and everybody's going to be shopping for their drug cards next year. For 2025, the cost of your plan plus the cost of your medications at your favorite pharmacy or through mail order cannot exceed $2,000 a year. And that's been signed into law. That wasn't done by an executive order. So if Congress wants to change that, they have to actually pass another law that actually throws all of that expense back onto people who are on Medicare. I see that I have somebody here who has a hand up. I just don't know what I can do with that, because we're not taking questions and answers in here. You're being reverted back to your original financial advisor for any questions. So I'm at the end of my 90 minutes. I do this on a fairly regular basis, and I knew this is where we were going to end up. I hope you felt that this was a meaningful use of your time. Again, you can contact me through your financial advisor. I have partnered with your financial advisor to be their Medicare specialist. If you have any questions that pertain to your own personal situation, I want to thank you